Добрий вечір.
Добрий вечір.
Добрий вечір.
Добрий вечір.
Зараз попросимо виключити абсолютно всіх, хто в зумі. Я маю на увазі мікрофон. Чи нас чує пані Оксана? Чує. Пані Оксана, скажіть щось, щоб я була впевнена, що я вас чую.
Вечір добрий, пані Катерино.
Добрий вечір. Чи нас чує пан Фегерт?
Yes, excellent. I can hear you.
Great. Чи нас чує наш основний спікер сьогоднішнього дня, пан Plener?
Yes, I can hear you all right.
Great, thanks. Тоді, пані Оксана, будь ласка, розпочинаємо. Спочатку ви, потім професор Фегерт, потім я, а потім Пол.
Домовились. Вітаю всіх учасників сьогоднішньої зустрічі, сьогоднішнього вебінару. Не може не тішити те, що кількість учасників, яка під'єднується до скарбниці міжнародних знань, неуклінно зростає. Я Оксана Zbitneva, керівник координаційного центру з психічного здоров'я Кабінету міністрів України, який є імплементаційним партнером Всеукраїнської програми ментального здоров'я ТИЯК, яка впроваджується за ініціативи першої леді України Олени Зеленської. Я з великою вдячністю і теплом вітаю голову Європейського товариства дитячих психіатрів професора Jörga Фегерта. Пане Фегерте, вітаю вас і обіймаю. І президента Австрійської асоціації дитячої та підліткової психіатрії професора Пола Пленера, який буде сьогоднішнім спікером і дасть лекцію, вебінар про самоушкоджуючу поведінку, підтримку, лікування, діагностування. Проєкт, до якого ми всі долучені, реалізується в межах Всеукраїнської програми ментального здоров'я і за підтримки Міжнародного фонду ООН UNICEF. Пані Катерино, щирі вітання із великою вдячністю. Дорогі друзі, це вже 4-та зустріч, і ще раз підкреслю, що кількість фахівців, які доєднуються, лише акцентує на тому, що знань не буває багато. Особливо для України, яка в війні має величезну потребу в сучасних, скомпільованих знаннях. І користуючись тим, що ми реалізуємо цей проєкт, такі знання є для фахівців в Україні. Вам сьогодні плідного вечора, плідних знань і задоволення від того, що фахівцю надають наснаги, впевненість в тому, що він знає, що робитиме сьогодні і завтра. Бажаю всім наснаги. Дякую.
Прошу професора Фегерта.
Yeah, thank you very much, Oksana Zbitneva. It's a pleasure to see you again here on the screen. And we are very happy that we could organize that series of talks and that these presentations are so well accepted. We have now about 350 people in the audience, and we always take a video of the presentations so that persons that can't attend can see it at another moment. So that's very, very helpful. I also would like to thank Kateryna, who is working with us very closely to bring to you the first certificates of our medical chamber on these courses, translated to Ukrainian with the support of the Ukrainian authorities. So you will have the proof that you attended these seminars, and I'm very grateful that all the organization, all the translation always is done in such a perfect way. So thank you to everybody who supports it. Today it's my great pleasure to introduce to you Paul Plener. Paul Plener studied medicine in Vienna and then came to my department as early as a medical student. He came for a short moment and then he did all his medical training at my university, at my department. And he is a pioneer in research of self-harm. When he did his doctoral thesis, that earned him a summa cum laude, a very excellent thesis, the field was just developing, and he is now one of the worldwide experts in that field. He had senior research fellowship at the Department of Child and Adolescent Psychiatry in Mannheim for 1 year. Then he came back as a full professor to my department. And since 2018, he is head of department in his hometown in Vienna. And I'm glad, Paul, that you will present today. And I have to excuse myself. I have a meeting of the German Board of Family Affairs to the Federal Ministry, and the board meeting will be at the end of your talk. So I will leave the presentation and leave you alone with the discussion, but I'm sure you will manage it. The floor is yours, Paul.
Well, thank you very much for the kind introduction, both of you. I'm going to talk about self-harm today, and I'm very well aware that Dennis Ugrin did a talk a couple of weeks ago on self-harm and therapeutic assessment, which kind of spares me some time because you already know about that. And knowing some of Dennis' slides, I think we don't double each other. But starting off very quickly with my conflict of interests, as you can see, I received some research fundings from different agencies, but they don't really belong to that specific talk. And I'd like to start off with some sort of definition issue here, because there's always the question, what is self-harm? And you can see here some sort of a delineation between self-injurious thoughts and behaviors, whether they've been undertaken with or without suicidal intent. And with regards to suicidal intent, there's suicidal ideation, suicide planning, and suicide attempts. And with regards to non-suicidal intention, there's self-injury. I'm going to talk a lot about self-injury thoughts, and also suicide threats or gestures. And self-harm has become some sort of an umbrella term, as it is now used, and it refers to the intentional self-poisoning or self-injury, irrespective of type of motive or the extent of suicidal intent. So self-harm is like a very broad term about everything that people do to harm themselves without looking into the intention of the specific behavior. And one of the things that we always interested in that respect is how often does this behavior occur? And this is the biggest data set so far. It has been published as a meta-analysis, drawing data from 260 publications in adolescents, including more than 500,000 participants from different studies. And they showed that the overall self-harm lifetime prevalence from around the world is like 17%. And if you go for different separate definitions, NSSI is like 23%, and the past year self-harm prevalence is around 13%. One thing you can easily see here is that it's more common in female than in males. You can see that the most common type of self-harm is cutting. You can also see here that people who self-harm have a higher rate of suicidal ideation, but also suicide attempts. So there's a risk ratio of 5 to 9 for suicide attempts. The most frequent reason that is stated in studies with regards to the function of self-harm is a relief from mostly negative thoughts or feelings. And it's very interesting to see that although there's a high prevalence of this behavior, nearly half of the persons telling you that they already harmed themselves once in their lifetime only do it once or two times, like 47%, and then stop it. And these are not the persons that we're particularly interested, because as you all know, working with children and adolescents have a tendency to do, let's say, dumb things, or to try out things that adults would say aren't very good behavior, but a lot of them stop, but half of them progress, and these are the ones that we really care about. You can see here the prevalence rates from different countries from that meta-analysis, and you can see here that the mean starting age is between 12 and 13 years of age. And it seems that when you draw all the different prevalence rates from the studies in a diagram, that the prevalence rates seems to be increasing. I've talked about the starting age, which is between 12 and 13 years of age. And there's also a few studies, or a couple of studies, who looked into the starting age as kind of a predictor for the trajectory that it's taking. And it seems that a starting age earlier than 12 years goes along with a higher frequency of self-injury. NSSI is the acronym for non-suicidal self-injury, if you see it on the slides. There are more methods, and there are more hospital-related visits due to self-injury. This is another graph that we did, putting all the longitudinal studies on an x-axis of age. And you can see here that self-injury seems to peak at around the age of 15, and then it slowly goes down. And it does so even without any intervention. So self-injury decreases over age. And a lot of adolescents who self-injure stop the behavior when they grow 18, 19, or 20. This doesn't necessarily mean that they grow healthier, and we have quite some evidence that they're changing behavior towards substance use problems and other mental health issues, but they seem to stop cutting. When we look into functions, so why do people hurt themselves? There's been this 4-function model that's you can find in the literature very often. And this is very easy to understand. There are 2 main functions. People hurt themselves either because they want to change their own state, which is called automatic or interpersonal functions, or they hurt themselves because they want to change something in the social context, so more as an interpersonal functions. And there are both positive and negative reinforcement mechanisms involved. So let me give you an example for that. Automatic positive reinforcement. So you want to change something in your own state, means like you hurt yourself and then you get a really good feeling, like a high, a rush, or kick. There are only very few people who say that this is the primary reason for self-harm. Most people say it's because of automatic negative reinforcement, which means there's a bad thing, like a negative emotion, anger, frustration, fear. They hurt themselves and then it stops. We now know that this is kind of a quick fix. It usually lasts for 30 to 60 minutes, and then you're back again on the negative emotion. It's something we learned in the last 5 years, so it's just for a short time. But that's the most common reason that is stated for self-harm. Whereas on the interpersonal level, social positive reinforcement would mean that you hurt yourself to show others how bad you feel. So kind of a social signal that you're sending out to your environment. Whereas social negative reinforcement would mean that there's a negative social situations that you want to get out of, like having to attend class, having to go out with the family for a vacation, something like that. You hurt yourself and you don't need to participate in that particular activity. And if you put all of them into a meta-analysis, and there have been a couple of studies that looked into functions of self-harm, you can see here that within the intrapersonal functions, the most commonly cited functions is emotional regulation, as I already told you. And this is particularly to escape negative states. Whereas The second most common function is self-punishment. So people harm themselves to punish themselves in a way. With regards to interpersonal functions, it's about communicating distress, interpersonal influence, and to punish others. Next question is about risk factors. And this is interesting meta-analysis because it only drew data from longitudinal studies. So we're talking about real risk factors, not about some correlations that have been found. And the strongest risk factors, and you can see here the odds ratios put down here, are a prior history of self-injury, a cluster B personality disorder, hopelessness, the prediction of the patients that they will do it again, a history of abuse, prior suicidal thoughts or behaviors, or if they were in contact with self-injury through a peer, which doubles their risk. So being in contact with other persons who actually injure themselves seems to be a risk factor. And this is very interesting when it comes to working in an environment where there are a lot of adolescents together, just in like in youth welfare or in schools or in child and adolescent psychiatric inpatient wards. And there's been quite some studies on the effect of social contagion. There's a systematic review, and it has been found over and over again. So this is the very first study that's been published on the subject in 1989, showing that within a child and welfare institution, if there's one person who starts to self-injure, then it spreads around the same institution. And we've been doing some studies in schools back in Ulm, doing social network analysis. And you can see here the red dots are the one with non-suicidal self-injury. So we asked them who you're friends with in the class. And then we did these network diagrams. We never published that. But interestingly, I just found just lately a newer recent publication that were using network analysis on a much, much larger sample than we did. But interestingly, they found the exact same thing, namely that the persons who injure themselves, they have a bridging function. They connect other groups. They are not in the center of groups within the classrooms, but they are the connection dots standing somewhere between different groups in the classes. Very, very interesting finding. And it seems that people who have high centrality in the social network, so they are very popular among other youth, have a lower incidence of self-injury, as you can see here, as this will be these dots. There could be something said, and I'll just briefly touch on that to the limited amount of time that we have, about the neurobiology and the mechanisms involved. We know that there's some involvement of genetic factors. That's not too big, like somewhere in the range between 30 and 50% of the variance explained. And these are data from twin studies. And of course, we have to think about epigenetic changes following adverse childhood experiences. Because what we do see in persons who hurt themselves is that they show, in some instances, very similar profiles to persons with a post-traumatic stress disorder. For example, a blunted cortisol response when it comes to social stresses, and the hyperactivation in the amygdala and the anterior cingulate cortex, regardless of the emotional content that they are viewing. So we can see that there are some prequels to self-injury, adverse childhood experiences, that is the acronym for that, among them. Something within genetic disposition, maybe something having to do with early experiences with their caregivers, although we don't have any good literature on that. And then with all this predisposition, they enter in a state where stress happens, and through the act of self-injury, we see that things change. We have quite good evidence that they come into a state where they can control stress better. And this is an interesting thought when thinking about psychotherapeutic treatment, You have to offer something to them to be able to manage stress. Otherwise, they don't have any chance to get away from self-harm. And these are people who really do have a great necessity for regulating emotions. This is a heat map from an ecological momentary assessment study. So they were using prompts on the smartphones and asked them, how do you feel? And to explain that heat map, if there was a large discrepancy between I feel good, I feel bad, then it gets redder. If they feel the same between two different points of prompts, then it's green. And you can see easily here that those with a history of self-injury, they tend to go back and forth between emotions, between high emotions, very rapidly. So there's a need for emotional regulation. And coming from the field of neuroimaging research, when you present them emotional stimuli while they're in the scanner, they have a harder time in reappraising emotions. So if you show negative pictures to them or negative emotionally valence pictures, and you ask them to reappraise the emotion and turn their emotion into something good, we could see that healthy controls use their prefrontal cortex to control amygdala activation in that task. But those with self-injury or self-harm have a harder time in doing so. So they have a poor ability to downregulate negative emotions. And this is actually the first study that we did back then in adolescents with self-injury. And we were able to show that when they were in the scanner and they were looking at different emotional pictures, negative, positive, or completely neutral pictures, they showed a higher activity in the amygdala and in the anterior cingulate cortex. So their limbic system seems to be hyperactivated regardless of the emotional content. It's like they're on all the time. So now what happens when you confront them with pain? So when you injure them while they are lying in the scanner. This is a very interesting studies that have been done by the colleagues in Mannheim, and they used different methods to obtain pain. So they were using electromagnetic pain, thermal pain, or they were even in one study cutting the participants in the scanner. And intriguingly, because normally if you hurt somebody, your amygdala activity and your ACC activity will increase. But something strange happened with those with a history of self-injury. As soon as they experienced the pain, the activity in the amygdala and the anterior cingulate cortex decreased, and the activity in the dorsolateral prefrontal cortex increased. And interestingly, also the functional connectivity between the dorsolateral prefrontal cortex and the amygdala increased. So we do see here something like getting in control when it comes to emotional regulation that happens after incision. And this is very interesting when you think about what they tell you clinically, because a lot of those adolescents will tell you that they experience some very negative emotion and they hurt themselves and it just stops. And this is something that the colleagues in Mannheim were able to show in their fMRI studies. Another intriguing thing is that people who hurt themselves often seem to have a higher pain threshold. So this is a meta-analysis, including 32 studies, and they all point in the same directions. If you have somebody who hurts themselves for a while, their pain threshold increases, their pain tolerance increases, and their pain intensity that they perceive decreases. It seems that his hyperalgesia is habitual, so you can get away from it. If you stop hurting yourself for more than 6 months, pain threshold goes back to normal, which, so this allows for the conclusion that this is not something that is there from the beginning, like a genetic trait, but something that has been learned throughout time as it decreases after stopping self-injury. And there's been quite some studies that started 14 years ago on the role of endogenous opioids, because of course they're involved in pain processing and self-injury. And the very first study that was conducted, they were using liquor and so cerebrospinal fluid from persons with a borderline personality disorder. And they were able to show that within liquor, there were lower levels of beta-endorphin and methencaphalin. And they came up with the hypothesis that throughout cutting, where those endogenous opioids are released, people regain homeostasis in their opioid activity. And recently, this has been done in adolescents now with self-injury. And they were using heat pain and using plasma endorphin levels because it's much more easy to obtain than liquor levels. And they found the same thing. And even a more recent study using saliva beta endorphin and asking them via smartphone prompts to have saliva swaps with them and do a saliva swap before they hurt themselves in their daily lives, give a prompt on their smartphone. And if they have hurt themselves, do another saliva swap. They were able to show that beta-endorphin decreases before self-injury when there's an urge to self-injure, and after self-injury, it increases. So there's some sort of a homeostasis thing that seems to be going on also in adolescents who self-injure with regards to endogenous opioids. Another thing that we need to mention as a huge risk factor is bullying. And there has been quite a couple of longitudinal big studies that show that bullying and peer victimizations are predictors for taking up self-harming behavior. And you can see here that is not a longitudinal, but a cross-sectional study that the odds ratio for self-harm was 12. So you have a 12-fold likelihood to engage in self-injury if you have been bullied within 2 to 3 times within the last 3 months. And so there's the question whether there's anything specific about social stresses with regards to self-injury. And these are studies that will all be conducted using a TRIA social stress test. So this is a social stress paradigm that is depicted here. So what has been done is that the participant is standing in front of 3 people who are all wearing white lab coats. They're all staring at you, not giving you any feedback, not verbally, not non-verbally, and there's a video camera. And you have to talk about yourself, and you have to perform mathematical calculations, because this normally puts people in stress. And what you would expect to see in that situation is a strong cortisol peak that then, because cortisol, there's a negative feedback loop there, downregulates itself and goes back to normal. The very interesting thing that has been shown in now 3 different studies from 3 different groups is that adolescents with NSSI show blunted cortisol response, as you can see here, here, or even here. And this does not mean that they're specifically cool in that situation and that it's easy for them to manage. The opposite is true, because if you show these videos to raters after that, and they are blinded for the condition of the participant, you can see here that those with a history of self-injury, they seem to be far more stressed out to the raters because they have a difficulty of getting stressed down because there's not an adequate cortisol peak that you would look. With regards to peer victimization, we also choose another paradigm. We use cyberball, which is a social exclusion paradigm that you can do in the scanner. You can see it here. So you're told that you're playing with 2 other participants and they're in the room next door to you, so you don't see them while you're lying in the scanner, and you can move your hand in the scanner and you can throw the ball, if you receive it, to the right or the left. But after a couple of minutes, this happens. So you don't receive the ball anymore, and you wonder what the other ones are doing because you're out of the game. And this kind of hurts. And it has been called social pain 20 years ago by Naomi Eisenberger, who invented the paradigm. And we know that our pain metrics in the brain, so the centers that are involved with pain processing, they get activated as soon as we are excluded in that game. So we were interested in looking into the pain metrics in adolescents with NSSI, and we compared adolescents with depression and NSSI adolescents with depression without NSSI. These are the green ones, to adolescents with depression and NSSI. And they were matched for their depression score. So it's not about depression, the story here. It's a clinical control without NSSI versus NSSI. And we compared them to healthy control. And you can see here that in the pain metrics, there was a higher activation when they were socially excluded. And we also did a total brain analysis, seeing that there was a hyperactivation of the salience network. So these are the regions involved in the brain to see whether a stimulus that's come from outside is salient to me or not. And it's like putting a weight on it. And we can see here that social rejection is far more salient for adolescents who hurt themselves. And this actually leads to an idea of a dual systems model. And this, of course, also has to do something with brain development. We can see an imbalance between the affect regulation network that increases activation throughout adolescence and the emotional salience network that peaks its activation in adolescence. And I found this model to be very interesting when thinking about why is it something that we see primarily in adolescence. You can see here that when we talk about brain development, adolescence is a period with heightened reward sensitivity. So their reward sensitivity system is on. And we also know that adolescence is a period in which everybody between the age of 12 and 17 has a heightened sensitivity to social exclusion. That's the norm. So we have kind of a vulnerable phase. So if there's something going on with social rejection in that particular phase of brain development during adolescence, of course, there's socioaffective pain. And then you get socioaffective pain in low-risk use who don't have any other comorbidities, and they can show an adaptive response. Whereas if there are any high risks in there and socioaffective pain hits, and of course they have a very good reinforcement learning centers they're all on, then NSSI and the MET socioaffective pain relief feeds back into that reinforcement learning that works very well, and then self-harm can occur. What can you do for assessment? Clinically speaking, these are the things that you can think about when you encounter somebody who hurts himself for the very first time. What happened before? In their environment, what happened in their body? What were their thoughts, feelings, or their behaviors they were doing before? How high is the urge to self-injure? How many wounds are there? How do they typically start? And when do they finish an episode of self-injury? Because normally it's not a single cut. Normally there are many cuts, and then do it again, they stop for a while and then re-enter it. Is there any pain? Is there great bodily harm? And in which body regions are self-harming wounds? We know that any wounds that are somewhere on the thorax or in the abdominal area or in the genitals or in the neck or in the face, they come with a higher rate of suicidal attempts than wounds who are only there on the arms. There have been some studies on that. So location is very important. What are words or maybe symbols that have been carved into the skin? Which tools do they use? Where is self-injury located? sorry, we already had that on the body, but where do they go to self-injury? So what is the location where it happens? Do they injure themselves alone or together with others? What happens afterwards with regards to their body, their feelings, their thoughts, and what happens in the environment? Do they go to anybody and tell them about their self-injury? Is there any motivation to stop? Are there any more details? And there's been this German guideline on the clinical the clinical guideline for self-harm, and it says that with a basic assessment, so if you encounter a person for the very first time, first check for a somatic assessment. If there's any physical treatment to be needed, like stitches or any surgical interventions, then this is the primary thing you need to look for before you even go any further. Then you should do a full mental health assessment, and with a special emphasis on assessing suicidality, because we know that there's an overlap. And you should ask for frequency and methods that have been used for self-harm. And there should be factors influencing self-injury assessed, both from the family or the social group, the peer group. So what happens in the outside world that leads them to self-harm? And you should also assess for what happens afterwards. So what are the consequences of that? And as part of the psychological assessment, you could use specific questionnaires. There have been some tools that have been developed mainly for research purposes, but they can be of use also in the context of doing clinical assessments. For example, if there's some adolescents that doesn't want to talk, you can see here a picture taken from the functional assessment of self-mutilation by Elizabeth Lloyd Richardson. You can see here a list of different things that they did to harm themselves. Then they ask about how long have you been thinking about it before you do it? How old were you when you performed it the first time? Did you experience pain? And then they offer a list of different functions. And by checking that list and the ratings on that, you can see whether it's more for within the 4 factors models for automatic negative reinforcement, automatic positive reinforcement, or social negative and positive reinforcement. So it's some kind of an answer sheet or an answer key for that. And I think that if you really want to use scales for clinical assessment, I think that's a good thing to use if you have somebody there who doesn't want to talk and who feels better by filling out some forms. So how can we help them? And I think the picture says everything. So we don't know anything, to be honest, about psychopharmacological treatment in that particular age group that is really ailing the persons. So this is kind of a depressing story. This is taken from the last Cochrane review that has been published in 2021 about interventions for self-harm in children and adolescents. And you can see here, you don't need to be able to read it. I just brought it to you to say there's everywhere there's the same sentence. So there has been different options that have been observed within the Cochrane review. So whether that be SSRIs or antipsychotics or anti-epileptical drugs, stuff like that. And there is no evidence so far on any of these agents being able to really decrease the frequency of self-harm. So there is no evidence of a helpful psychopharmacological strategy for self-harm. Of course, you can use psychopharmacological interventions for sedation, like in a skills-based setting where they try out different skills for emotion regulation themselves. And if nothing works, then they can turn to the physician and say, well, as a last resort, before I hurt myself, so I need to get something to get away from this urge to self-injure. But you have to be aware that, of course, benzodiazepines, who are often used in inpatient setting, doesn't seem to help with regards to self-harm. So it's more about conventional antipsychotics if you want to do anything with regards to emotional regulation. So which are the targets for therapy in self-harm? Emotional regulation is key. So recognizing emotions, learning about skills and how to alter negative states. Another part are social skills. How can I communicate to others? How can I ask for help if I'm not feeling well? How can I solve problems? And with regards to interpersonal coping, of course, some of the patients share a history of trauma, and this needs to be tackled in a trauma-specific therapy. You can also talk about automatic beliefs and core pains, and about self-hatred. And in some families, you need to address family issues. And we do see that more and more brief interventions seem to be extremely helpful with these adolescents. They don't necessarily have to go into therapy for 2 years. And this is a systematic review on brief interventions. You can see here Dennis Ugrin program here. And all of these interventions have shown that they're helpful in decreasing self-harm in adolescents. But it has to be said that none of them was able to show that they were better than treatment as usual. So if there was an RCT going on in reducing self-harm. There's this review on self-harm and suicide attempts, and they said that the best bets you can get is for dialectical behavioral therapy of adolescents. They have replicated effect in diminishing self-harm and suicide attempts, and also for CBT. And what do these successful programs have in common? They involve the family or supporting persons. They do emotional regulation skills. They do problem-solving skills, and they teach communication skills. There's this bit more recent review on 26 RCTs for self-injurious thoughts and behaviors, coming up with like the same thing, that DBTA is most helpful, and CBT and DBTA is level 2, probably efficacious, and you have some family therapy here as well, and psychodynamic therapy individual. With regards to the Cochrane self-harm report that has been published in 2021, it also mentions DBTA, showing a lower rate of self-harm repetition and individual DBT, whereas the effect of mentalization-based therapy on adolescents is uncertain. And we just published a meta-analysis this year showing that there's no effect of MBT on self-harm. For other things like personality disorder, of course, there are effects, but not on self-harm. And we published that meta-analysis a couple of years ago, showing also that DBTA has the largest effect sizes on self-harm frequency. So this is something that seems to hold true throughout different meta-analyses. So what are common elements in the treatment for self-harm and suicide attempts? This is like a systematic review. And the format should be an individual therapy, plus involving the caregivers. It's very good if you can have like a 24/7 phone coaching available, which is often restricted or limited. And when you go for content, one of the things that you need to do is safety planning in advance, social or interpersonal skills, mindfulness tools, safety counseling, and talking about impulse control. So you have to include caregivers, provide skills, you need to emphasize safety, and work on the therapeutic alignments. Which brings me to core elements of NSSI. So you need to have clear contracts in beforehand. What should happen in the case of suicidality on NSSI? You need to build commitment for treatment. You need to do some psychoeducation beforehand and identify factors that trigger or maintain NSSI. And you need to provide alternative behavioral skills so that they can solve problems. And of course, you need to look into other mental health issues. For example, if there's an anxiety disorder, a depressive disorder, PTSD, and treat them as well. And I think I'll probably stop here because you already heard about Dennis' program, therapeutic assessment, that of course needed to include since it's a program that was able to show that people can get a lot more motivated to go into therapy and to stay there for longer. Dennis has been showing 2 RCTs by now, but I know that he talked about that, so I'll briefly skip that. And I want to now close this session by telling you that, of course, there are some app-based interventions that you can use as an adjunct to therapy. For example, the Therapeutic Evaluative Conditioning app. There are 3 RCTs showing that as long as the adolescents use that app, they decrease their self-harming behavior. But as soon as they stop using the app, they increase again back to their levels before. And the same is true for online diarying. So if they do some sort of a diary each day, writing down in different styles, doesn't matter which style, what happened the other day, it seems that their frequency decreases, but if they stop using the diary, it goes back down. And there's this very new publication by Jörg showing that an online therapy as an adjunct to treatment as usual is really working well. So they were developing an online therapy, and normally the people were seen in treatment as usual, and then they did the online sessions, and they had also some sessions with psychotherapists online, and they have given a mobile app, and the parents received sessions online as well. And you can see here that adding on this online adjunct, this is emotional regulation, individualized therapy for adolescents, reduced the frequency of NSSI very well. And I want to end by mentioning that we need step care approaches because we have limited resources. So at first we need to get the people into therapy, and therapeutic assessment can help here to get them into therapy and also to increase their motivation. I think that we have a lot to learn still from online psychotherapy as an adjunct and to keep people motivated and in there. And then we should go for brief manualized interventions like the cutting down program as a CBT intervention, which only has like 10 to 12 sessions. We also need to look into sleep and physical exercise, since we know that there is something here that can decrease the risk of self-injury. And only in those who don't respond to that, we need to use higher intensity treatments. And we don't know anything about psychopharmacology, so we have to still learn about that and about other forms of biological treatment like transcranial stimulations or stuff like that. So we don't have any evidence for that right now. So to end this, as I've shown you, self-harm is a highly prevalent phenomenon, and it often serves an affect regulation function, and it works for the persons. Psychotherapy helps to reduce self-harm. We also have to say that treatment as usual in nearly all of the studies helped as well. Not as good as the manualized interventions, but still with an effect size of 0.6, which is not bad. And we need to still get better at lowering thresholds to therapy. We need to get better at increasing scalability, add new components like digital strategies as augmentation strategies. And I would advise to look out for sleep and physical activity, since we're only understanding how they could really influence NSSI frequency. And that was about it, and thanks for your attention, and I'm open for any discussion.
Пані Оксана, ви хотіли б щось додати? Зараз ми якось всіх потеряли на екрані, я не бачу всіх. Виведіть мені всіх 4 нас знову. Всіх 4 нас виведіть, будь ласка.
Професор Фегерт, певно,
Нема професора
відключився.
Фегерта наразі, так? Да, добре, тоді нас 3. Пані Оксана, ви щось хотіли сказати?
Так, я хотіла ще раз подякувати професору Фегерту за те, що для України в цьому проєкті професор зібрав дійсно флагманську групу експертів з усього світу, для того, щоб ми могли можливість дати українським фахівцям ці знання і доступ до найсучасніших досліджень. А ще хотіла дуже подякувати нашій аудиторії, тому що кількість людей, яка була протягом цієї лекції, була майже 430 осіб, активні запитання в чаті, що доводить, що є величезна потреба в доступі до цих знань. І хотіла особливо відзначити, що на цій зустрічі фахівці з усіх регіонів України. І тішить ще й те, що є представники, викладачі медичних університетів України. І я вам за це окремо дякую. А тепер прошу, дякую, пане Пленер. Можемо питання-відповіді ще встигнути дати. Так, пані Катерино? Дякую.
Так, дякую. Мені вимкнули звук. Буду зачитувати питання і сподіваюся, що перекладачі встигнуть за нами. І так, питання від Ірини Яворської. Дякую за змістовну доповідь. Підкажіть, будь ласка, щодо коморбідних розладів, при яких зустрічаються самоушкодження, окрім ПТСР. Я часто зустрічала у практиці самоушкодження разом з розладами харчової поведінки, а також щодо досліджень терапії при таких станах.
Okay, with regards to comorbidity, I think going from the most common to the more exotic ones. Of course, post-traumatic stress disorder, borderline personality disorder, depression, and anxiety are the most common comorbidities. With regard to eating disorders, as you mentioned, it's more common in bulimia than in anorexia. But we do see high rates of self-harm in anorexia as well. And often we do have different reasons for eating disorders. For example, in bulimia, we see self-harm as a tool of emotional regulation, whereas in anorexia, we often see self-harm as a tool of self-punishment. Because they are not reaching their goals or they're feeling too thick or anything. So there might be different reasons, but there is a higher percentage. And because you asked about how to tackle them with regards to comorbidity, I think that you could use or should use skills in all of the different comorbidities. And of course, you need to address the other diagnosis. If you have, for example, a psychopharmacological compound, like in depression, you would also use an antidepressant, for example. But then when it comes to, what is the function? You really need to understand. Because as I told you, within eating disorders, we have a total different field in bulimia and anorexia. So you have to really do this individually and ask them, how does it help you? So what are you doing it for, to be able to work on that? And this is, I think, key for using that. Whereas all of them could and should receive some skills training.
Дякую. Наступне питання від пані Ляни Козик. Спостерігаю певне задоволення у підлітків від самоушкодження. Чи є поняття залежності від селф-харму?
That is a very, that's a very good question. And the answer is that there's still an ongoing debate in the research community whether it could be viewed as an addiction. We did a study a couple of years ago and trying to look for different subtypes within self-harm with that question in mind. And the thing is that we could see that, like, of all those kids who self-harmed, maybe around 10% fulfilled addiction criteria. So they had the feeling that they could not stop despite they knew that it was bad for them. And of course they were doing it despite and they had some sort of a tolerance increase. So they needed to harm themselves more to get some effect out of it, but it was not in the whole population. It were those who were the most severe self-insurers who showed addictive properties. One thing has to be said, we don't encounter any craving like in other addictions. So it's not like they are feeling good and then they start to feel like an itch and say, well, I could use a little self-injury now. This does normally not happen as it does in other substance use disorders. So there's no craving involved. But apart from that, within the top 10%, we do some addictive properties.
Пані Анастасія Літо питає, що ви підкажете стосовно підлітків, котрі заперечують дану проблему, яка в них присутня?
Okay, so what to do with them? The thing is that if they don't want to get into therapy, I think you should start by, as usually, as would be the strategy in other things like substance use disorder as well, with some sort of motivational interviewing and go for ambivalence, just to get some sort of a foot in the door. So if they're sitting there in front of you and telling you, you can do whatever you do, I'm not stopping it. I know these patients. Then I'm like, okay, well, fair enough. I mean, I'm not there all the time. I can't stop you. You're correct. That's okay. But maybe there are some times in your life when it's just not good to self-insure because it's not feasible. And since you use self-injury as a stress regulation mechanism, there are situations in every life where there's stress and where self-injury is not a good idea. For example, if you have a math exam, if you go on a first date, if you have the examination for your driving license, then it's simply not a good idea to hurt yourself just before that, to decrease your stress. Would you agree? And most adolescents say, yes, I do. And then you continue and say, well, maybe check out some other options just for these very few stressful moments. And of course, you can hurt yourself if you'd like to, but maybe just try out some other different strategies for that. And this is by trying to get a foot in the door. It doesn't necessarily work all the time, but it's not a good idea to go up front there and tell them that, you know, I don't know, I'm a therapist and you need to listen to me. And we need to work on that. Because if there's no motivation, first you have to build it.
Таке ще питання від пані Марини Петрушевської. Самоушкодження при розладах аутистичного спектру. Що робити з такими дітьми?
Oh, that's another very good question. So I was mainly talking about self-harm that is not stereotypical or as a, you know, as a symptom of neurodevelopmental disorders like autism or Lesch-Nyhan syndrome or cognitive impairment whatsoever. Because we know that in this respect, in neurodevelopmental disorders, we see much more stereotypical forms of self-injury. Although we also would need to think with them about other non-harming ways to get rid of frustration or to soothe themselves or calm themselves. So it serves a bit of a same function. In this respect, we could also try some psychopharmacological interventions. And there has been some support for using antipsychotics in this respect, but also some support for the opioid antagonists like naltrexone, just in this very small population. That's one thing you could think of.
Ольга Юдіна питає, що робити лікарю, якщо підліток просить не казати батькам про самоушкодження, казати чи ні?
That's a tricky question because we're talking about a behavior that is not clearly suicidal, where at least in our law, regardless of what the adolescents say, you're allowed to tell the parents if there's any danger or threat to the life involved. Whereas we're actually not allowed to tell them if there's not an imminent threat and adolescents ask you not to disclose this. So it might depend on the legal situation, and I have to say I don't know about the legal situation in the Ukraine, but in Germany and Austria you wouldn't be allowed to disclose this to the parents if the adolescent asks you not to, with the exception of suicidality. So personally, I don't tell the parents if there's no imminent threat for suicidality or if there are no larger wounds that need stitches, for example. So if you need to get somebody to the hospital to be stitched up because there's I don't know, muscles or tendons or nerves that has been hit or there's a large bleeding, then you'll need to tell the parents. And at least in Germany and Austria where I've worked, there are some legal background for that. But apart from that, if we're talking about superficial self-harming behavior that is away from any suicidal stuff, I would not disclose it to the parents if the adolescent asks me to.
Це я роблю паузи, бо перекладачі попросили, і я не знаю, чи вони занадто довгі, чи короткі. І так, наступне питання. Від Антона Городокіна. Чи є взаємозв'язок між ризиком самоушкоджень та початковим періодом лікування селективними інгібіторами зворотнього захоплення серотоніном? Чи потрібно це враховувати?
What we do see in the initial period for SSRIs is that people gain more activation. And personally, I've seen people starting to or let's be explicit. Nobody started self-injury when I gave them an SSRI. I've never seen that, and there are actually no reports on that. But we do see that people increase the frequency of self-harm after initiation of SSRI, since their activation increases, whereas their mood is still a bit down. So I think, like for example, with behavioral activation, I've seen that clinically, and there are some studies actually reporting on that fact, although one have to say that the really good study, like a randomized controlled trial that was looking specifically for that, like the Tordia study, they haven't found that effect. They found the effect for venlafaxine, so an SSNRI, which is, of course, much more activation included in that, but not for SSRIs.
Під час свого виступу професор Пленер згадував як анкети, так і різні інструменти для вимірювання і оцінки. І пані Ліана Козик і Ольга Гаврікова питають, чи є ці інструменти, і чи раптом хтось знає, чи є вони українською.
I'm not too sure, and to be honest, I think that probably Denis Ugrin knows about tools that are available in Ukrainian. But this is maybe also a question to the people in the chat, because maybe somebody knows. Among the tools that are freely available that I could mention, that you could easily find and download, is the Ottawa Self-Injury Inventory. But it's quite a long tool, you have to say. There's many pages involved in that. You could find it on the net if you go for Ottawa Self-Injury Inventory. And another tool that is available is a clinical interview that's called the Self-Injury Thoughts and Behaviors Interview, or shortly it would be called SITB. And that is available from the Harvard homepage. And there are many versions in different languages, although I'm not sure if there's an Ukrainian version.
Пані Вікторія Толок питає, якщо дитина-підліток відмовляється приймати ліки, бо не відчула ефекту від них, чи є сенс в психотерапії, і чи розглядається медикаментозне зловживання селф-хармом, чи це спроба самогубства? Як лікують таких дітей амбулаторно чи стаціонарно?
So the one thing that I'd like to state first is that normally you would treat self-harm on an outpatient basis because they tend to get worse in inpatient settings because their self-harm often increases. They often get into a dynamic with other inpatients and they often increase in severity. So I would keep them outpatient as long as possible if there's no suicidality involved. Second, it does make sense to really look into psychotherapy, even if no medications are taken, because we know that psychotherapy works in those patients. So even if there's a patient that refuses to take any meds, go for psychotherapy.
Пані Майя Грищук питає, чи є дослідження про частоту селф-харму жінок та чоловіків, мешканців міст та сіл, рівнями інтелекту, типами особистості.
Yes. Well, for gender, I've mentioned in one of the big slides in the beginning that there's more female than male people injuring themselves, and we have even higher rates in people who identify themselves as or have a transgender identity or non-binary. They have the highest rates. And then one has to say that it seems to be not an urban-rural divide. So you can find the same percentages urban in the city as well as in the countryside. And one has to say with regards to cognitive abilities that some smaller studies have found that self-harm is connected to higher intellectual abilities, like a higher IQ. But this is only very, very few evidence that we have on that question.
Уляна Сосновська питає, які способи емоційної регуляції запропонувати підлітку, який практикує самоушкодження?
For emotional regulation, there are different levels. We have these high stress levels where you only want to keep away from the self-injury. So they're in a very high stress mode, and we try to use skills that offer some sort of a very sharp like sensation, like something to smell, ammonic acid, for example, or eat some chili or some wasabi, so something very acidic or very sharp, or with a pungent stench. Or they could use something on their skins, like ice cubes and stuff like that. But the ultimate goal is to not always react when they are in a high stressed mode, but to learn throughout therapy, through mindfulness training, that they can learn about their thoughts and their feelings so that they can detect stress at an earlier level. So when they are not in high stress mood, but they kind of in a middle stress zone, they find out about themselves like, okay, I'm feeling stressed right now. It's not quite high, but it can go in that direction. Let's do something. And then they have a broader variety, and we would really train with them how to connect to other people, to peers, and ask them to do something with them, to get away from the thoughts, to interact with them. And we try the strategy so to get them out of the thoughts and feelings so that they don't increase in stress and end up in a high stress category. So this is more of more levels that you can approach. You start with the high stress skills, but then you need to talk about things that they could do when they're in a sort of a middle stressed field.
Руслана Погорєлова із asking, якщо самоушкодження проявляються укусами кінцівок, ударами кулаками по голові, при наявності анорексії та депресії у підлітка, хлопця, то це самоушкоджуюча поведінка чи більше суїцидальна поведінка?
Well, you can't tell from the outside. You have to ask the patient. That's the answer, because it can be both. And people can harm themselves for reasons not suicidal and have suicidal thoughts as well in the same person. So when it comes to the behavior, I'm always asking, so what is it for? And normally they will tell you so what they're doing for. So my main and primary question is, how does it help you? And you get a lot of good answers to that question normally. And I would really, you need to ask the patient. It's no use of, having some signs from the outside, because it's in your mind. There's no way of getting around asking the question.
Ми зараз очікуємо, чи є ще питання, чи ні. Зараз, секундочку. І якщо питань не буде, то будемо закривати. Зараз, ще секундочку. Бо нас дивляться на 3 платформах, і ми дивимось, де є питання, а де немає. Ні, питань більше немає. І ми дуже дякуємо вам, професор Пол Пленер, за такий класний вебінар і за те, що ви відповідали на багато питань, в тому числі про клінічні кейси. І ще раз дякуємо дуже всім, хто був присутній на цьому вебінарі. Навіть був момент, коли в нас було 477 людей, що дуже дивно для вечірнього часу. І ми вам дуже вдячні, що ви на цей вебінар прийшли. Пані Оксана, будь ласка, закривайте. Ми вас не вимкнений в вас.
Дорогі колеги, друзі, окрім слів вдячності, хочу ще подякувати за те, що цей вебінар у нас пройшов без жодної повітряної тривоги, і нам не прийшлося йти в укриття, звертати нашу скарбницю знань, а тож тихого всім і по можливості мирного вечора. Бережіть себе і своє ментальне здоров'я, бо коли ви в ресурсі, ви будете помічними для своїх пацієнтів. Дякую, пане Пол. Сподіваюсь, не востаннє. Будьте з нами, у нас ще є багато тем для розмови. Дякую, пані Катерино.